One is cardiogenic shock, hypovolemic shock, and septic shock. Coming to various parameters, we should look at various parameters like what is the pulse pressure difference, diastolic pressure difference, the extremities, whether cold or warm, or capillary blood filling time. Then look at JVP and basal cryptations in the lungs, the S3 gallop, the X-ray chest, echo, and any infection, evidence for infection. Was coming to pulse pressure. What happens to pulse pressure in cardiogenic shock, in hypovolemic shock, and in septic shock? Pulse pressure decreases. Pulse pressure is the difference between systolic and diastolic. 120 minus 80, 40 is a normal pulse pressure. In cardiogenic shock, pulse pressure decreases. Even in hypovolemic shock, pulse pressure decreases. But the mechanism in septic shock is vasodilatation. Peripheral vasodilatation is the main mechanism. So there will be widening of pulse pressure in septic shock. So normal pulse pressure is 40. In cardiogenic and hypovolemic, it will be around 20, 30, 20. And in septic shock, it will be more than 40. Coming to diastolic pressure. Diastolic pressure will be a shock state, low in cardiogenic and hypovolemic shock, but there is significant lowering of diastolic pressure in septic shock because of peripheral vasodilatation. Then extremities, cold in cardiogenic, hypovolemic cold, and initially warm, and in late stages can be cold. Coming to capillary filling time, nail bed blood return time. What happens in cardiogenic shock? Decreased. Even hypovolemic shock is decreased because of in peripheral vasodilatation and warm extremities, filling time will be increased rapid in septic shock. The next one, coming to JVP increased in cardiogenic shock. Even Rayleigh lungs cryptations will be there in cardiogenic shock with pulmonary edema. The evidence of pulmonary edema will be present in cardiogenic shock. Even S3, S4 gallop, they are present in cardiogenic causes. So, raised JVP, pulmonary edema evidence, cryptations, and S3 gallop, S4 gallop, they are present in cardiogenic cases. Then, what are the X-ray chest findings in cardiogenic shock? There will be cardiomegaly and evidence of pulmonary edema, battering pulmonary edema, cardiomegaly, and there will be X-ray evidence of pulmonary edema. In hypovolemic shock, no cardiomegaly, normal size heart. Even decreased peripheral vascular markings can be present if there is severe hypovolemic shock. So, normal size heart in hypovolemia. In septic shock, unless there is evidence of some respiratory infection or some cardiopulmonary cause, even X-ray chest will be normal unless there is evidence of lung infection. So, we should look for source of infection, site of infection and source of infection for the cause of septic shock. Okay? So, these are the various parameters in these three types of shock. And another type of shock is obstructive shock, cardiogenic, hypovolemic, septic, and obstructive shock. So, cardiogenic, hypovolemic, septic, distributive shock, and obstructive shock, like in pulmonary embolism, there is obstruction to right ventricular output. So, various parameters are one starting with cardiac output, SVR, systemic vascular resistance, PVR, peripheral vascular resistance, and SVO2, systemic venous oxygen saturation, right atrial pressure, right ventricular pressure, pulmonary artery pressure, pulmonary capillary wedge pressure, that is pulmonary artery occlusion pressure, and cardiac function by echo evidence, and intravascular volume status by IVC findings. So, in cardiogenic shock, cardiac output is low. If cardiac output is low, systemic vascular resistance increases. Now, what happens to SVO2 in cardiogenic shock? Systemic venous oxygen saturation. What happens to SVO2? SVO2 will be low. Okay. Coming to formulas for deriving SVO2. First, we should know delivery of oxygen to the tissues, DO2. What is the formula for HbO2? HbO2 is 1.34 into hemoglobin into saturation. And what is the formula for equation for dissolved oxygen, soluble oxygen? 0.03 into PO2. So, we will eliminate dissolved oxygen. We will take only HbO2. What is CaO2? Delivery of oxygen is cardiac output into CaO2. CaO2 means arterial oxygen content. Arterial oxygen content. Arterial oxygen content means HbO2 plus dissolved oxygen. HbO2 plus dissolved oxygen. We will eliminate dissolved oxygen. So CaO2 means 1.34 into hemoglobin into saturation. Here hemoglobin is in grams per deciliter. 1.34 is 1.34 ml of oxygen bound to hemoglobin in grams. So it is in deciliters. So for dissolved oxygen also, calculation also, the solubility of oxygen depends on temperature. It is inversely proportional to temperature. But at 37 degrees centigrade, there will be 0.03 oxygen solubility per each millimeters of mercury rise in PO2. 0.03 into PO2, dissolved oxygen formula. So it is in deciliter, but here 0.03 ml per liter per millimeters of mercury. Solubility is 0.03 ml per liter per each millimeters of mercury of PO2, partial pressure of oxygen. Here, if partial pressure of oxygen is 100, then 100 into 0.03. Here it is ml per liter. We have to convert it to deciliter. So we'll add 0.03 by 10. So 0.003 into PO2. What is the normal arterial oxygen content? Normal arterial oxygen content is 20 ml per deciliter. So in 20 ml per deciliter, 19.7 HbO2, only 0.3 dissolved oxygen. Coming to the arterial and venous values, what is the normal PaO2? Partial pressure of oxygen is 90. PvO2 is 40. PaO2 is 90. Arterial oxygen pressure. PvO2, venous oxygen pressure is 40. 90, 40. SaO2 is, normal SaO2 is around 97. SvO2 is around 73. Here arterial oxygen content is 20 ml per deciliter. Venous oxygen content is 15 ml per deciliter. In 15 ml, roughly 0.1 will be the dissolved oxygen, rest will be the HbO2 bound form. So what is the difference between arterial oxygen content and venous oxygen content? CaO2 minus CvO2. So CaO2 is 20 ml per deciliter. CvO2 is 15 ml per deciliter. So 5 ml per deciliter is the arterial venous oxygen content difference. CaO2 minus CvO2. So 5 ml per deciliter means 50 ml per liter. For 5 liters blood volume, 250 ml per 5 liters blood volume. So oxygen uptake, VO2 is around 250 ml per minute. So formula for DO2 is delivery of oxygen is cardiac output into CaO2 is delivery of oxygen. Then this is VO2, uptake of oxygen by tissues. So artery, capillary and vein, the tissue. So delivery of oxygen to the tissues, DO2. It depends on cardiac output, hemoglobin and saturation. Cardiac output, hemoglobin and saturation. So VO2 means uptake of oxygen by the tissues. So this uptake is difference between arterial oxygen content and venous oxygen content. So CaO2 minus CvO2. What is CaO2? 1.34 into hemoglobin into saturation. What is CvO2? 1.34 into hemoglobin into SvO2. Here it is SaO2. Here it is SvO2. So cardiac output and 1.34 hemoglobin are common in both the equations. So we should know oxygen extraction ratio, O2 ER. Oxygen extraction ratio is VO2 by DO2. Oxygen extraction ratio is VO2 oxygen uptake by the tissues by delivery of oxygen. That is around 25%. DO2 normal DO2 is 1000 ml per minute, around 500 to 600 per ml per minute per square meter. In body surface area, it will be around 560 ml per minute per square surface area. So DO2 is around 1000 ml per minute. Here arterial oxygen content, the difference is for 5 liters is 250 ml. So DO2 is 1000 ml and VO2 is 250 ml per minute. So normal DO2 is 1000 ml. Oxygen uptake is only 250 ml per minute. So VO2 is 250 ml per minute. With body surface area, it will be around more than 110 to 160 depending on the body surface area, ml per minute per body surface area. So here oxygen extraction ratio is VO2 by DO2. What is VO2? Cardiac output into CaO2 minus CvO2. CaO2 means 1.34 into hemoglobin into SaO2. CvO2 means 1.34 into hemoglobin into SvO2. So in VO2 and DO2, cardiac output 1.34, hemoglobin, they're all common. So finally the equation will be SaO2 minus SVO2 divided by SaO2. So VO2, cardiac output into CO2 means 1.34 into hemoglobin into SaO2 minus 1.34 into hemoglobin into SVO2. Again here DO2 means cardiac output into 1.34 into hemoglobin into SaO2. So we'll eliminate cardiac output 1.34 and hemoglobin. They're the common both numerator and denominator. So finally the equation for oxygen extraction ratio is SaO2 minus SVO2 by SaO2. So with 100% oxygen saturation, SaO2 will be 1. So with 100% oxygen saturation, finally it is 1 minus SVO2. If oxygen saturation 100%, we will take SaO2 as 1. If it is 90%, we will take it as 0.9. So oxygen saturation 100%, then this will be 1. Here it is 1 minus SVO2. Finally, oxygen extraction ratio is 1 minus SVO2, the venous oxygen saturation. If oxygen extraction ratio is more, there is more oxygen extraction, what happens to SVO2? 1 minus SVO2. If extraction is more, SVO2 decreases. Venous oxygen saturation decreases. If extraction is more, venous oxygen saturation decreases. Here it is SVO2. So this is mixed venous oxygen saturation. Mixed venous oxygen saturation. And the bedside with central venous catheter, we will get SCVO2. What we get is SCVO2. Central vein oxygen saturation is almost equal to SVO2. What we get is with central venous catheter SCVO2. So here SVO2. If cardiac output is low, normal VO2 oxygen extraction is 25%. In the first stage, if DO2 cardiac output is low means decrease the delivery of oxygen. DO2 will be low. If DO2 is low, there will be increase in oxygen extraction. So it will maintain normal VO2. In the first stage, if cardiac output is low, DO2 will be low, delivery of oxygen will be low. Then there will be increased oxygen extraction. Normally it is 25%. There will be increased oxygen extraction. So it maintains normal VO2. Uptake will be normally maintained. But the limit is, maximum limit is up to 50%. So now, what is the normal SCVO2? SAO2 is around 98%. SVO2 is around 73%. Okay, 65 to 75%. Normal mixed venous oxygen saturation is 65 to 75%. If DO2 is low, if there is decreased oxygen delivery, what happens to SVO2 initially? SVO2, extraction increases. Then what happens to SVO2? It will be less than 65%. Venous oxygen saturation will be low. So it will be less than 65%. But the maximum limit is 50%, physiological limit. Maximum physiological limit is 50%. If SVO2 is 50%, it means a threatened oxygenation state. Tissues are in impending threatened oxygenation state if SVO2 is 50%. So normal is 65 to 75. If cardiac output is low, DO2 is low, this SVO2 will be less than 65% initially. But maximum physiological limit is up to 50%. If SVO2 is 50%, means there is impending tissue oxygenation defect. Tissue oxygenation is the most important endpoint. So if in cardiogenic shock, cardiac output is low and SVO2 decreases. Initially less than 65%, then it will be around 50%. In cardiogenic shock, there will be backward filling of pressures. PCW will be high, pulmonary capillary wedge pressure is high, pulmonary artery pressure will be high, RVP will be high, RAP will be high. In the echo, and dilated LV with poor contractility. Here in IVC, we should look for whether it is large IVC, normal IVC or small IVC, whether it is collapsible or not. So in hypovolemic shock, again cardiac output is low, SVR will be high. SVO2 in hypovolemia, means again cardiac output is low, so low SVO2. But because of hypovolemia, the pressures are low, normal or low. Okay? In echo, the normal size chamber or a decrease in size of chambers, obliteration of cavity. If there is severe hypovolemia, there can be low volume or obliteration of cavity. IVC will be small and collapsible. Here in cardiogenic shock, large and non-collapsible. In cardiogenic shock IVC, there is dilatation of IVC, large and non-collapsible. In hypovolemic shock, small and collapsible. So coming to septic shock. Septic shock, always start with SVR. SVR is low. Systemic vascular resistance is low. If SVR is low, cardiac output increases. What happens to SpO2 if there is severe septic shock? If there is cytopathic hypoxia. If there is cytopathic hypoxia means there is no uptake of oxygen by the tissues. In cytopathic hypoxia, in severe sepsis, so there is no uptake of oxygen by the tissues. Then what happens to SpO2? SpO2 increases. That's the most important point. See? SpO2 increases in septic shock. Okay, normal, even ScVO2 is around 70 to 80, will maintain more than 70%. So if initially if it is 65, the sudden increase in saturation, then we have to look for whether there is any significant cytopathic hypoxia or not. So because SpO2 will increase in septic shock. These pressures, if cardiac output increases, there will be decrease in backward filling of pressures. So these pressures can decrease, normal or decrease. Backward filling pressures, PCWP, pulmonary capillary wedge pressure, pulmonary artery pressure, then right ventricular, right atrial pressure. There will be increase in cardiac output. So there will be decrease in backward filling pressures. Coming to the echo, in septic shock, cardiac output, they can be hyperdynamic heart. Because of vasodilatation, there will be hyperdynamic heart. IVC, normal and collapsible. In obstructive shock, classical example is pulmonary embolism. Pulmonary embolism. So in pulmonary embolism, PA pressure increases. Here PA pressure increases, and RV pressure increases, RA pressure increases. Because of right ventricular enlargement, there will be increase in right ventricular systolic pressure. There will be septal shifting of interventricular septum towards left ventricle. That can cause low cardiac output. RV output decreases because of severe pulmonary hypertension or pulmonary embolism. RV output decreases. And because of septal displacement towards left ventricle, even LV output can decrease. So cardiac output decreases with obstructive shock. Mainly obstructive shock means obstruction to the cardiac, so it can be pulmonary embolism or cardiac tamponade, even pneumothorax. They all come under obstructive shock. Even a significant arterial occlusion, obstruction to the cardiac outflow. The cardiac output decreases, SVR, systemic vascular resistance increases. Here, pulmonary vascular resistance is most important. PVR will be high in pulmonary embolism. Again, SVO2 decreases because cardiac output is low. So we discussed about SVO2, DO2, VO2 and SVO2. And another parameter is SaO2 minus SVO2. Normal SaO2 minus SVO2 is around 25% because oxygen uptake is 25%. Oxygen extraction ratio is 25%. So difference will be around 25%. What is normal SaO2? Around 98. SVO2 around 73. The difference is around 25%. So 65 to difference will take 20%. 25 means 20 to 30%. So if DO2 is low, delivery of oxygen is low, means low cardiac output state. Anemia, low cardiac output state. What happens to the difference? What happens to the difference? DO2 is low, extraction increases. Oxygen extraction by the tissues increases. Oxygen uptake by the tissues increases. Then what happens to SVO2? SVO2 decreases. Then what happens to difference? SaO2 will be maintained normal. Uptake of oxygen by tissues is more. Then SVO2 decreases. Then what happens to difference? Difference increases. From a normal SVO2 73, it decreases to 65, 60. So difference increases. So if SaO2 minus SVO2 is more than 30%, it means that oxygen uptake by the tissues is more. It means that delivery of oxygen is low. So oxygen uptake by the tissues is increased. Then SVO2 is decreased. So difference increases. So the difference is important. SaO2 minus SVO2. So if it is more than 30%, means DO2 is low. And the maximum limit, physiological limit is the difference will be up to 50% because oxygen extraction is ratio, the limit is 50%. VO2 50% is the physiological limit. So if the difference is 50%, that means threatened oxygenation state. Tissue oxygenation is a threatened oxygen state. So what happens if there is in cytopathic hypoxia, in severe case of cytopathic hypoxia, where there is no tissue oxygenation? Imagine a situation where tissue oxygenation is severely affected in cytopathic hypoxia. There is no VO2. VO2 uptake is less, oxygen extraction is less. Then SVO2 increases. If SVO2 increases, the difference decreases. So if it is less than 20% means cytopathic hypoxia. SaO2 minus SVO2 normal is 20 to 30%. If DO2 is low, the difference increases more than 30%. If the difference is more than 50%, threatened oxygenation state. But if it is less than 20%, means cytopathic hypoxia. Normally we will get SpO2, pulse oximeter. Pulse oximeter oxygen saturation is SpO2. So if SpO2 SaO2 relation we should know. So what is the relation? What will be the difference between SpO2 and SaO2 measurements? If both are same, we can rely on SpO2 only. Normally the variation is less. With oxygen saturation of more than 70%, the variability is very less. Variability will be 1% to 3%. We can rely on SpO2. So SpO2 minus SpO2, and instead of taking SaO2, we can rely on SpO2. SpO2 minus SpO2. SpO2 minus ScVO2, central venous oxygen saturation. So we will get central venous oxygen saturation by central venous catheter. We will get SpO2 with pulse oximetry. We can rely on SpO2 minus ScO2 in the bedside examination. So what is oxygen extraction ratio? O2 ER, VO2 by DO2. O2 ER oxygen extraction ratio is VO2 by DO2 in the percentage wise into 100, which is 25%. Then VO2 is equal to O2 ER into DO2. So oxygen extraction ratio is VO2 by DO2. So VO2 is equal to DO2 into O2 ER, because we are interested in VO2. Uptake of oxygen by the tissues is the most important parameter. We should get VO2, because the difference between congestive cardiac failure, heart failure and cardiogenic shock, the important difference between heart failure and cardiogenic shock, suppose if you take cardiac output parameter, it is low in both cases. CVP and even SVR equally affected in both situations, heart failure and cardiogenic shock. But the difference is this VO2. VO2 is low in cardiogenic shock. If VO2 is low, we can label it as cardiogenic shock. Cardiogenic shock means less than 90 millimeters of mercury pressure, at least for 30 minutes. Then we will label it as cardiogenic shock. Or more than 90 with support, vasopressors support also, we can mention it as cardiogenic shock. But the important difference between heart failure and cardiogenic shock is VO2 is low in cardiogenic shock. So here VO2 is DO2 into oxygen extraction ratio, and we are interested in SvO2. We can derive an equation like 1 minus, because what is O2 ER? O2 ER is SvO2 minus SaO2. 1 minus SvO2. Finally, the SvO2, another equation is 1 minus VO2 by DO2. So 1 minus, so if VO2 increases, SvO2 decreases. If DO2 increases, 1 minus VO2 by DO2. If DO2 is low, delivery is low, uptake of oxygen by tissues will be increased, then SvO2 will be low. So if it is VO2 by DO2, if DO2 is low, SvO2 will be high. But here it is 1 minus VO2 by DO2. Okay, if DO2 is low. So we should know these equations. One is HbO2 equation, dissolved oxygen equation, and delivery of oxygen equation, DO2. That is cardiac output into CaO2. And VO2, oxygen uptake by the tissues. That is cardiac output into CaO2 minus CvO2. Then oxygen extraction ratio, VO2 by DO2. Then other equations for SvO2. So some other causes of shock are cardiac output will be high. What are high output states? High output heart failure, Paget's disease, thyrotoxicosis, AV malformations. Paget's disease, thyrotoxicosis, AV malformations, there will be high output cardiac failure. And with low cardiac output, in low cardiac output states, we should check for right atrial pressures, normal right atrial pressure and fluid non-responsive states. Normal right atrial pressure with fluid non-responsive states. Important conditions are spinal shock, anaphylaxis and adrenal insufficiency. In these three conditions, cardiac output is below and fluid non-responsive states. Patient is not responding to fluids, we should look for adrenal insufficiency. Check right atrial pressure, it will be normal. Then rule out adrenal insufficiency. Look for anaphylaxis and rule out spinal shock states. So low cardiac output but high right atrial pressures and fluid responsive. In pulmonary embolism, RV infarction, cardiac tamponade, initially they will respond to fluid challengement. So we should know the 4 causes of shock: cardiogenic, hypovolemic, septic and obstructive shock. And then rare causes also we should look for: high output cardiac failure states, fluid responsive states with high right atrial pressure, fluid non-responsive conditions with normal right atrial pressure.